I am excited to be with this panel today. We had a lot of fun meeting each other yesterday, and there was some great energy in the room. So I would love to have each of them introduce themselves and give you a little bit about their background and why they're here today and what they're passionate about. So I'm going to hand it over to Adil.
Welcome, everyone. I am very excited to be here. My name is Adil Yang. I was the CEO and co-founder of Medumo. We were recently acquired by Philips about 7 weeks ago, so I'm a new Philips employee. Still learning the ropes, if you will, but my background is in medicine, so I was a physician, internal medicine, and then I got bit by the entrepreneurial bug, seeing the problems that we were facing day in and day out. I started a company originally in the e-learning space to help train allied health professionals, and then went back into medicine and saw the operational challenges, decided to start Medumo as a way to solve some of the operational challenges that we were seeing, the no-shows, the cancellations, and then from there, build a whole platform to help automate a lot of the work that the nurses and schedulers were doing to communicate with the patients. And then from there, we grew the company and eventually got acquired by Philips. So excited to share that journey with you.
Thank you.
And I'm Jessie Israel, and first I want to start off with a thank you. I feel a little humbled and totally embarrassed to be up here with these overly qualified people. So these folks have been really amazing, and I want to thank Philips for giving me the opportunity to speak with them. But I'm a nurse by training, and I'm just taken a new role as the CEO for two clinically integrated networks here in the Denver market. So I oversee the Colorado Care Partners, which is wholly owned by Health One, the health system, as well as Practice Health. Between those, that's a group of about 1,100 providers, including employed, non-employed, mostly primary care and some specialty care. Before I got into this role, I've done a lot of population health. And what that meant for my prior health system, because it can mean something different really for any health system, was anything that wasn't fee-for-service. So inpatient, ambulatory, government programs, commercial programs, Medicare Advantage programs. In that role, we stood up two clinically integrated networks. We stood up two accountable care organizations and participated in a third, achieved shared savings in one, using a very data-driven approach, data-driven, physician-led, which we can talk about in a little bit. Some other things that I've done that I'm pretty proud of is worked on the inpatient joint bundle, but that part's not that exciting, but we did reduce cost of care by more than 40%, again, through a data-driven approach on elective hips and knees throughout the health system. I've acquired a home care agency and integrated alternative payment models into the home care space. And then as far as what I'm passionate about, number one is I just love healthcare. I honestly wake up every single day excited to go to work and excited to do what we do every day. And I hope that I'm solving these problems the day before I die. Not these problems, the other problems that are going to be the day before I die. And then what really makes my heart sing is seriously ill patients. I think maybe I'm a glutton for punishment, but spent more than 7 years working in long-term acute care hospitals. And that's just where my heart, those are my people. So looking forward to helping those seriously ill patients in the future.
That's awesome. And trust me, you belong up here. We're really happy to have you. So how about you, Ram?
Morning, folks. Ram Srinivasan. I'm the CMO of Advanced ICU Care. We are the nation's largest independent provider of tele-ICU services. So to give you an idea of my journey, a lot like Adil, trained as a physician, mostly in the Washington, D.C. area where I still am. I still practice at the bedside, and I do the telemedicine work as well. So having the multiple vantage points, I think, is really helpful because, telemedicine's here, it's here to stay, but how do we make it, more effective? How do we leverage technology to really help these patients? And to give you an idea of the problems that, we're trying to solve, really comes down to equity, which is patients don't discriminate where they're going to fall ill. If they live in a community where they don't have the ability to get to a tertiary medical center, and they can't be transported, that patient remains ill, and in critical care, time is very important. We've got to be able to care for that patient in that environment, in that local hospital, and that's what we try to do at Advanced ICU Care, is connect, bigger city folks where we've got more staff, more physicians, to smaller communities where they don't, and give them a 24/7 care model by leveraging technology like Philips eCare, and also working out operational inefficiencies, and that's all part of that journey. So that's in a nutshell what we do. We now have 9 centers that we operate from as essentially satellite control stations, and we've just grown to about 90 hospitals now in the last year.
Okay.
Awesome. How about you, Mike?
Good morning. It's a pleasure to be here and a privilege to be with this esteemed panel. So I'm Mike McGillian from McMaster University. I'm an associate professor of nursing, and I'm a nurse scientist at the Population Health Research Institute. We have trials active in over 86 countries globally. And my background, my PhD work was in self-management of illness and empowering patients to really become active in their ongoing life management and chronic disease management. And so I really became interested in how we can use innovative digital health technologies to really capitalize on the power of the people that we have in healthcare and patients, and really draw out the talent that we have to solve problems today, like the efficiencies we struggle with in our single-payer healthcare system, and I'll talk more about that later. So a pleasure to be here.
Awesome. Well, welcome. You know, it's funny, we come from such diverse backgrounds, and yet we're all clinicians. Mm-hmm. And we've been there and worked with the patients and touched them. And we're using our skill sets and our leadership in different ways now. And so when you think about the quadruple aim, what do you feel like are the greatest challenges that you're facing today or we're facing that need to be addressed and to really meet that? And I'm gonna start with you, Ram.
Sure. Yeah.
I promise not to go to a deal more than once.
Yeah. I mean, I think it's a great question. Quad aim is top of mind for everybody. It's been an evolution to get to quad aim and finally integrating that the provider experience. I mean, because if we're not thinking about the people that are doing the work, how are you going to get all these other things achieved? Mm-hmm. And if you want to think to analogies, I think we always talk about aviation analogies and healthcare. We've seen all the books published. But if you think about that journey there, when you walk in and you're never going to meet really your pilots, the air traffic controllers, all these people. But if those things are not managed well, those people that are the end users of delivering that final product, well, that's where all the things break down. So I think it was very important to get to that. And in what we are doing, of course, you look at these things. Okay, improve patient experience. Mm-hmm. Thinking about an intensive care patient, I'm going to speak in my lane. That's what I do. That's a very daunting experience for a patient and a family. Intensive care unit is alarms, tubes, lines, potentially the person is not awake, a very daunting experience. How can a telemedicine solution help, at least for us? Okay, well, you think about this. If you've got a provider, a doctor that's rounding once a day, they come in, everyone is all just waiting, saying, hey, what's going to be the information today that we're going to get? What's the update, okay? And then they're gone. Why? They have to be. They've got to get on to whatever else they're doing, the rest of their patient roster. They may be taking care of more than just the intensive care unit in many models. So in what we're trying to do to improve that patient experience is availability. In a telemedicine solution, it's not just the tech, it's not just the labs, the vitals, but it's the ability that, let's say now, whether it's the patient or the family, a question comes up after those care rounds. We can send you a person on that screen to talk to you. And although I may not be in the room, I just have to be able to convey some level of communication on what is the plan for today. Maybe there was a misinterpretation. Because the 24 hours that elapse between the time that the physician rounded to the next time, those don't feel like 24 hours.
No.
They feel like 2 months, right? Mm-hmm. So that's, if I was to speak to that, that would be one thing. And I know that's a soft thing, but it really matters to people, right? Mm-hmm. And especially if you're trying to integrate a tech solution in there, that human factor piece is highly important. I'll speak to the other ones really quickly, the better health outcomes. Clearly in this model, again, if we're able to dedicate a person who is what I call an inch wide and a mile deep, right? As opposed to a mile wide and an inch deep, someone who is intensive care, that's what they do. We've given them this patient roster, and we say, hey, these are the people we're responsible for, and we put you in a situation when that's the only thing you're doing. I've got a chance to be a little bit more laser focused in the way I'm approaching care. Versus I have a bedside staffing model where that person's a little bit more spread out. They're just not able to, be as focused on the task at hand. And for staff experience, we try to lift some of these, things that are a constant, worry for someone in the intensive care environment. You may have put a care plan into place, but it doesn't end with the daily rounds. There are going to be multiple calls from nursing that, okay, there's a deterioration.
We try not to bother you.
No, and you know what, though? I think that, and I get that, that's been the traditional feel. When I speak to nurses all the time, we go on site, we get a lay of the land before we implement a remote technology, because it can't just be the people behind the screen, right?
Yeah.
You've got to be humans that are connected to this interface.
Sure.
And we have this exact conversation, which is, we want nurses to not feel that you are bothering us. It shouldn't be a bother. The nurse is the #1 person who is the advocate of the patient. They are the ones that have the one-to-one relationship with the patient, the family, the monitors, and are able to escalate a sense of urgency to the physician in this case, who's got to then make decisions. And if you think about it from an improved staff experience, it's not just the provider staff, it's the nursing staff, it's the respiratory team, it's all the people that are involved, and that's how we're trying to do it. And with the lowering the cost, of course, you're leveraging technology, you're leveraging, more people to be focused on things so that you can try to pool resources, and that's how we're trying to do it.
That's awesome. Well, you have 3 nurses on the panel, so we
I know. Hey, listen, I ain't gonna.
We appreciate that you see us as key.
I'm outnumbered.
We've always seen ourselves that way.
Exactly. Yeah, absolutely.
So, Jesse, what do you think? I mean, is there a portion of this quadruple aim that you think is the most challenging to take on in your leadership role?
Yeah, I'm going to go a little bit of a different direction outside of
That's okay.
each one of these individual quadruple aims.
Yeah,
because
you don't have to.
I do think that I'm so glad that we added in the provider experience, because they're the ones providing, right, the care. So one of the things that I struggle with, and we talked a little bit about this yesterday, is this idea of thinking big while doing small. So both in the presentation and yesterday morning, it was how do we wake up and think of something really bold and big, and how do we take these hard rights and hard lefts and do something sweeping change, right? And then again, in the hard thinking and soft thinking is think bigger, and then think bigger again, right? And so I struggle with that, and then how do we really bring that down into what is the smallest goal that we can achieve today, and how can we get started with something that's better than nothing? And so this is very on both ends of the spectrum, is how can we release some of the decision fatigue and make the right thing the easy thing? And that is a lot of change management and a lot of process and a lot of stuff that really isn't that fun to do, but is really important to being able to free up space to do better, funner, cooler things, right? So decision fatigue, right? We all know about decision fatigue, and I think it leads to provider burnout, it leads to all kinds of barriers to being able to do bigger and bolder things. And so we've really got to find a way to release some of that and give people that easy button. And I'll give some examples around decision fatigue, some things that where in my own life that I think can help move things forward. So breakfast, how many of you wake up and you hate when your kids say, "What's for breakfast?" Right? So you start the day like, oh, I already have to make a decision. And this is how our providers feel about everything, right? Oh, I got to check that quality box. Oh, I was supposed to use that code. Oh, I never asked that person about their A1C and they were just in here, right? So it's exactly that thing of why not just make the decision once. So we have a thing at my house where we know what we're having for breakfast every day, because I really don't like to be asked what's for breakfast or what's for dinner, but that's separate. So it's getting to being able to get them to take it out of their mind and be able to put it into the place where they can deal with it in the future. It's like David Allen getting things done, right? We can all walk around and think, I need to buy cat food, but I shouldn't be thinking about that right now on the panel. I should be thinking about what we're doing, right? So we all do this, and it keeps us from being able to do the big things because we're so caught, and it's not the busyness, it is the busyness, but we're so caught in the minutia of doing the decisions that we have to make every day. So I feel like one of our biggest challenges is how can we ask ourselves a question only once? How can we say what's for breakfast only once? How can we say what is the agenda on the daily huddle only once? And then be able to move beyond that so we can do bigger and better things. So I think that's one of the greatest challenges. And then I'm also going to go just a tiny, I'll be fast on this so other folks can talk too, but a tiny bit on how we've moved away from the people experience. So we've got a lot of things that we're doing in healthcare that we're checking a lot of boxes, right? So we're really driven by quality measures. We're not entirely sure how meaningful those things are, but we spend a lot of time, energy, effort, just an incredible, enormous amount of expense on chart chasing and chart audits for quality measures. Is HCC-RAF the best way to risk adjust a patient population? I can't imagine there's not a piece of technology or something that can do that better. Why are we depending on physicians' memories to risk stratify our populations? And I think we've really got to rethink attribution. I mean, that's my third thing is you look at something like Oscar Health and they're attributing to the health plan and no longer to the providers. And we've really just got to think about things differently. I mean, those are three things that we spend more than half, at least in my world, to speak in my lane, of my energy on, is three things that don't enhance the patient's experience. And that just has to change. It cannot be sustained that way. So we've got to get back to our patients.
That's great. I think we have a lot to learn about decision making, and it does start, I think, with breakfast. Getting some of those stressors off.
Yeah, you should definitely do that. And then line up 2 weeks worth of outfits. I'm telling you, it's going to change your life. Just pick out 2 weeks and pick them up.
We only need just our own session with you afterwards.
Okay.
How about, Mike, from your, I mean, you really are a scientist, and when you look at the challenges we're facing, what do you think's up there?
Well, thank you. I've had the pleasure of practicing both in the United States and in Canada and other places. So when I consider the quadruple aims, I think there's some differences, but there's some real universals as well, as we discussed in our preparatory session yesterday. I'll come to that in a minute. Being in a single-payer system in the province of Ontario, I think when you consider the quadruple aims, we'd all agree these are crucial. To really move forward with those, it requires innovation. But I think we have to think broadly about what innovation means. In a system where we come from, the hospital systems are focused on, upgrade, trying to get to HIMSS level 6, right? They're behind the world in a number of areas, so resources are focused on trying to upgrade standards. And so here we are trying to innovate, but so much attention in a universal single-payer system is dedicated toward just base infrastructure upgrades. And you really have to, but these challenges present an opportunity, and it's an opportunity to be creative with inventive solutions. And I'm so glad to see improved staff experience. I think we'd all agree. And I think part of our discussion yesterday really resonated for me around a distressed workforce. And so, and it really, for me, rings true of Elizabeth Peters' work, my colleague from Canada, who's looked at this carefully in healthcare. I'll give you the example of the work that I work in specifically, which is the surgical population. So let's talk about cardiac surgery specifically. We know that in North America, if we look at the Cardiothoracic Trials Network data, there's 18% of all patients are readmitted within 60 days. It's huge numbers of patients. What's driving those readmissions? Arrhythmia, fluid volume overload. Problems that we could easily solve if we have the right solutions in place. And where's the source of distress for the workforce? It's increased pressure to discharge early, which, getting people home early is a good thing, we'd all agree. But worrying about, is that patient prepared? We know that base education, when you're being discharged from surgery, is insufficient. You go home and you're not prepared. And so how can we, in a system that is strained and tight for resources, use innovative technologies? And so we have to think about things. And I think it's really about focusing on the talent that we do have and capitalizing on it differently, because I don't think we do that well in some healthcare systems. Having been a nurse in the United States and in Canada, I can tell you the scope of practice is radically different sometimes. Why is it? This is probably universal. In many places, nurses, for example, are taking manual observations of patients using manual workflows to take vital signs and entering it into an EMR. It's a huge amount of time. Nurses are really expensive and a talented workforce. And so why are those processes not automated, right? Why can we not focus on the care of the patient and remove some of the manual workflows that are inefficient? How can we also use technology to link that talent directly into the patient's living room during recovery to avoid those readmissions? So I think there's opportunities to think creatively, even in the context of resource constraints, to help both clinician and patient and family.
Seeing a theme here. I'm wondering if you're going to add to that.
Well, yeah, I think that's a challenge. I think from my perspective, I'll speak from a provider and an innovator's perspective, which is that, when we look at the quadruple aim, and a lot of panelists here already mentioned, it's not really, 4 distinct kind of standalone values. I think it's really an equation, right? So if you want better patient experience, something's got to give. So oftentimes, what we see in the hospital setting is that, we have this no-show problem. Well, let's just have the nurses call the patients. So all of a sudden, you're trading provider experience for maybe solving the operational challenge or improving patient experience, or you're trying to focus on outcome, and all of a sudden you're putting more burden on the staff to solve those problems. So it's all kind of correlated, right? So to really crack that, let's call it balance, I think innovation is one way. Another way is really try to think about automation, and you mentioned that really well. And so from my perspective as an innovator, it's about how to design products and processes that intentionally do not put more burden on the staff or intentionally does not add to the cost. And it's really, really challenging to do, but that's one of the biggest challenges. And then the other one I would go about it is, I feel that everybody says it, but it's harder to perform and to actually make happen, and that's empowering patients. I think I've always been a big proponent of education, and from my first company to the second company, and there's this incredible power to be unlocked when the patients are engaged in their own care and are sufficiently educated. But again, I go back to this equation: how do you educate the patients without adding more work to the staff? And by the way, doctors aren't the best educators. I'll speak for myself.
You said it.
I mean, we went through 10 years of training, but it's clinical in nature. It's very procedural, but I can't remember a time when I sat down and got a full educational course about how to teach. So it's very challenging when you think about, all right, how do you educate patients without putting burden on the staff, and how do you really unlock that potential? Because when patients are engaged, all of a sudden the experience improves, the outcome improves, right? And the staff experience improves because now the patient is actually owning what they're supposed to do and not requiring the staff to repetitively remind them. And it lowers the cost because now you're not spending extra money on solving problems that would have been mitigated had the patients been more engaged in preventing that event from happening. So when we think about education, here's the biggest challenge. I'll give you a personal story, and really an origin story of why Medumo came about. So I was back in training, and I had this task of creating an educational binder for Binder. It's still paper binder. That's still the universal.
It's probably still there.
It's probably still there. I was tasked to create this educational binder for newly diagnosed diabetic patients. And I was very into it. I probably spent way more time than I was supposed to, but that was my thing. And interviewed experts in the field. I even had it designed. I spent my own money, made it look really good, so that the patients get excited when they receive it. It wasn't just some boring paper with lots of text. And I translated into 2 other languages. And I thought, this was going to be it. I'm going to make a difference. So on the day of sort of launching this program, we invited some of the newly diagnosed diabetic patients to the clinic, and we passed out the binders. We gave them a really fun, interactive presentation. And then that night on the way out of the hospital, I found my binder in one of the trash cans on the way out. And I was furious. I went through, and I went through probably all 5 stages of grief and recovery. And what came out of that was I said, something's broken. I mean, that's the challenge that we face. How do how do you talk to patients? I'm sure in that group of patients, some were really engaged, some really actually loved what we did, but obviously there were some that didn't. So how do you diagnose and find patients and identify how they prefer to be engaged and deliver the engagement through their preferences? I think that's been a challenge, for ages.
I was going to ask you a real quick question. It brings me back to, Eric Topol is, this author that, talks about all these different vantage points in medicine. Mm-hmm. The book is The Patient Will See You Now. Mm-hmm. And that's what I think of when you tell your story, because it's like, we feel we've got this idea of how to make it easy and
exactly.
I've got this solution.
Sounds so good, right?
But the person that's navigating the maze, right, has a different altitude view on it. The walls are really high.
Right.
We're looking at it from the drone view.
Right.
Right. So that's what I think of when I hear your story. It's really interesting.
It's interesting because the patient, traditionally and historically, probably when we were growing up as clinicians, it was, we let the patient know what they needed. We kind of, it was us telling them what they needed.
Yeah.
And it really is a different world we're in. Our patients are coming in and they've been to WebMD. They have Googled everything. They've got a list of questions. In some ways, it's almost intimidating to the provider when they come in and they're like, I don't have time to do everything. Yeah. And it's engaging them differently.
But I think that's a really interesting point and one that I've encountered in my professional practice, which is we've got to embrace that.
Exactly.
We've got to embrace that. And I'm not trying to make too many analogies here, but I think this one makes a little bit of sense for me. I look at that no different than people go to Yelp and read stuff about whatever, restaurants, or they go to TripAdvisor before they take a trip, okay? But I got a simple question for you, right? If you're gonna go climb the Himalayas, you can do all the reading you want, right?
Yeah.
You're gonna need the tour, you're hiring the tour guide still, right? And I think we've got to think about ourselves as tour guides in that way and say they're going to come with the TripAdvisor, the Yelp, all that stuff. Mm-hmm. How are we offering value then?
So it's interesting. So I think that's where it gets to our innovation. And how do we use innovation to support that? Because you're right, our first instinct is always to assign somebody to make that phone call. It's to assign somebody to review that chart. And how do we use innovation to really to do the things we need to do that are the right things and the best things, but to support the team and the patient? Because I think it's, people may call it innovation, but it's been a bit of a disruptor, and it's been many good things, but the EMR, for all of its good things, has been a disruptor in the quadruple aim for patients and providers and staff, because it's, the number one complaint I had as a medical group president was, the provider's so busy typing. We didn't have as much of a conversation.
Yes.
And what are they typing? They're typing, the EMR has been created around making sure you captured this code and you can bill this way, and you captured this quality and we get meaningful use and we didn't get penalized for that. It's not been built around how do we engage with our patients. So I'm kind of thinking back to yesterday. You really challenged me to think about how do we use those ideas from our keynote yesterday. Is we don't know what we need. We just know we don't like sometimes the EMR. And so when you think about so we have to think about what do they need and what do our patients need. Yeah. From an innovation perspective, you're all leaders. What do you see are the needs there? How do we bridge that and have technology support that and not feel like it's a barrier between us?
I'll try and take this one, and I'm going to take it in two different directions.
One is this
data-driven, physician-led, right? This sounds like a buzzword, but it's a real thing. And what that looks like, at least in my brain, is how do we use data? And one of the people yesterday that was in one of the breakout sessions, they said that they started with a data team, which I thought was brilliant, because that data really drives what is our biggest opportunity, right? So then we know what problem we're even trying to solve, and it's oftentimes not the problem we thought we were trying to solve, right? We've all run into that. And then from that opportunity, do we even have a process to solve that? So whether or not it's scheduling your cardiology appointment or discharge, it's a lot of times it's that we just don't know what the process is. What should I put in the PCP field? I don't know, right? So whatever the thing is, do we have a process, and then do we have the right people to be doing that?
Yeah.
So we often start at the people. I need a person to call the patients, but is this a real problem? What is the problem? Do we even have a process for that? So that's the data-driven, physician-led, and then that gets into a whole nother 4-point thing. As we said earlier, I have a slide for that on implementation, but that's separate. So I think that's how we can use the data in order to innovate and be sure that we don't get lost in solving the wrong problems, which we've all done, right? We've all gotten lost in interesting data and when to solve a wrong problem. As far as the technology piece, I think we have to be very, very careful about disconnection and connection. Every piece of technology should be saving our time, energy, and effort to get us back to human connection rather than supplanting that human connection. So if we're using our technology to, in place of, rather than to supplement, then we're going to get into trouble. And then we're going to kind of move into this, Snapchat consumerism space, which we all see teenagers happening, and they get a little disconnected, from reality in a way that teenagers only can. But we run the same risk of doing that if we're using too much technology in healthcare. So if we're connecting people, resources, payers, data, you name it, then I think it's useful. But it's when we start putting it up as a wall, a very, very high wall between us and other humans, then we're going to be in trouble.
Anything you want to add to that, Mike, from an innovation
Sure.
perspective?
Yeah, and I really like the analogy of the tour guide. Because to give you an example, so if we talk about the surgical population for a moment, so we know there's over 230 million major non-cardiac surgeries worldwide annually. If you're over the age of 45, 26% of you are going to have a major adverse event, and that's going to drive post-operative mortality. And so myocardial injury after surgery, 17% patients go home with a myocardial injury, nobody notices after surgery. Major bleeding, sepsis, big one. Infection without sepsis typically will bloom 11 days post-operatively, well after the patient's home, and it brews. So, I think there are things we can do. And in our group, we're really concerned about these issues in the surgical population. And so I like what all of you are saying, because we started with the patients. And so we asked, we have a single payer system in Canada and the United Kingdom, and we have colleagues there struggling with the same issues. And so we said, we asked patients to join us, trained them, gave them some basic training in soliciting, having a dialogue about what went wrong during your post-operative course. And so we wanted to distill from them what has to change. And so each patient was with a nurse, surgeon, clinical informatics person, biomed tech, engineer, and we really distilled we know the data, but what happened to you to lead to this adverse event. Yeah. So, when we think innovation, we started with the people, and the clinicians had ideas, the patients had ideas. We prioritized our list. We put out a call to the hardware and software consortiums in North America and asked industry to help us. And we had the good fortune of Philips coming forward. And so we really wanted to automate systems at the surgical ward level, remove manual workflows, nurses spending time typing. And so we're using the Guardian solution on surgery day, ward day 1. It's ironic that if you're a surgical patient, you're safest on the table. Patients and families are anxiously awaiting in the waiting room. Really, post-operative mortality is virtually almost non-existent, less than 1%. 70% of post-operative mortality is during the index hospitalization on the surgical ward, and 30% is at home. So how can we, the sophistication in monitoring with automation and the ability to respond instantly and use your clinical skills, how can we make that more of a picture in the surgical ward and at home? And so one of the solutions we're using is the Guardian system with cableless devices to monitor the patients constantly. When the patient's about to move to the next actionable wristband, an early warning system, the nurse is brought back to the bedside, right, to be able to focus on care. That 30-day window post-operatively is where we know all the bad things happen. And so we're using the Philips electronic transition ambulatory care system. There's a specially trained group of nurses who follow the patient right into the living room. They're collecting the patient's vital metrics, doing a video conference daily, looking at the wound, monitoring for infection, and really addressing the day-to-day issues in recovery. And it's enlightening the things that we are catching. So, because I think, back to the tour guide piece, you know, it's a bit of an illusion to be entirely consumer-oriented when we think about patients. Patients also need help and to feel cared for. And sometimes they don't know what they need. We need to help them. And so, you know, in just 35 patients alone, because we're auditing as we move forward, on this system, our nurses are adjusting, correcting, and fixing over 1,000 things in the 30-day postoperative course. And that is using the talent of our clinicians who are skilled, putting technology in place, and maintaining that continuity. The opposite picture is people are addressed by home care who has no context with the patient, multiple providers bidding for service. You've got one nurse coming in to do wound care, one nurse coming to do something else. Nobody has the picture. So I think solutions like that are driven by what people need to really help ease workflow and use our talent a little better.
You know, it's interesting because whether we're talking about the caregiver or we're talking about the patient, what we keep coming back to is we need to start with the people and what their needs are. And I love that that's really what adaptive intelligence is about. We don't want artificial intelligence. We don't want to replace our caregivers. We want to support them. And so I love that it always goes back to the people. But because it does go back to the people, we're a little challenged sometimes in adopting technology. We can be a little bit resistant to that.
Sure.
And I'm just thinking of you, Adil, you created a new technology to support. I mean, how did you find any challenges getting over the adoption of trying something new? Because you really created it from your experience. How did you face that with those you wanted to work with your solution?
It was a very iterative process, just like any technologies that you're trying to introduce to market. So for us, I'll share the journey a little bit. When we first started out, we had this vision. We were going to build basically a way for doctors to just prescribe these educational modules to the patients so that the patients can educate themselves, et cetera. That was, the instinct was, oh, here's a problem with patient not understanding what they're supposed to do and not, and therefore not coming to their appointments or procedures prepared or not being sufficiently educated. Many of them don't even show up. So we wanted to just tackle that problem. But oftentimes when you solve one problem, you create another problem. So and sometimes you can be as thoughtful as you can, but until you implement it, you don't really see that. So we had to bring sort of a prototype to practice really quickly. And within about, I would say, a couple days, we saw that, number one, the physicians just didn't even have time to prescribe. And that was a big eye-opener for us because we had thought, the value proposition here is that as a provider, you just have to spend, an hour preparing this, and then in the future, it's sort of one click and you don't have to keep doing it. That sounds great, doesn't it? But it was outside of their workflow to begin with, and even adding that one extra step was a no-no, right? So then it enlightened us to say, all right, how do we automate even that act of prescription away from the provider? Another problem was that we noticed that we had this app, which is very common back then, and patients weren't downloading it. Despite us, rewarding them, trying to get them, we even passed out gift cards, whatever we could.
What can I bribe you with?
Right, and this, you see this across the board with, I'm sure a lot of you know, MyChart and portals, and the adoption rate is extremely low because it's outside of their normal habit and their understanding. So we had to actually admit to ourselves our app isn't going to work, so we had to completely reinvent our product and made it an automated text, email, voice, phone call, and later on, and here's another one where we thought we were solving a problem by digitizing everything, because we're like, who wants paper these days, right? And then after we implemented, we were getting to about 80, sometimes 90% of the population, and there's always that stubborn 10% that just said, where's my paper? And we learned, okay, might as well join them and not fight them. So we added paper delivery as a functionality to our platform, because it's really about listening, and if you want to make an impact, you've got to recognize the additional problems that are popping up and then be willing to solve those as well. Another big one was a lot of other companies we saw were basically replacing the manual phone calling with this communication platform, but asking the staff to log into it every day and manage the communication with the patients. So, oh, today I have to send out these messages and I have to create these messages. And it was better than manual phone calls, but it was still taking up their time, right? And the adoption, it was creating another set of problem, which is staff trying to figure out how to use the software and how to incorporate that into their workflow. So that was a solution that created another problem. And then we went in there and we said, can we actually imagine removing that entire interface altogether and still make the product work? And it did. So those incremental kind of iterations actually ultimately led to the adoption of the system.
Yeah. It strikes me you have to be a bit humble when you're an innovator.
Extremely humble,
because you're going to have failure.
That's
you're
right,
going to have
for
things
sure.
that don't work, and your pride wants to say, but my app is great.
Oh yeah, you want to force it on them because you love, it's your baby, but that's not how it works. The only time that I find that, especially in healthcare or anywhere, that technologies can be adopted without solving some of those subsequent problems is when it's forced. And I will say EMR is one of those examples where because of regulation, because of a mandate, people have to take on EMR. Had the mandate not been there, forget about it. No one's gonna adopt the EMR. So, as technologists thinking about solving a problem, got to think outside of the context of regulation in order to actually solve, patients and providers' problems.
Yeah, that's great. Now you jumped up, Rob, when I asked this question, so I didn't want to leave you out.
Yeah, I mean, it was actually great that a deal went because it really primed the fact that when I think about EMRs, because I know that's where you started that conversation. Yeah, okay, it was thrust upon us. We as providers had very little input on how it's all going to go. You've got different brands out there, different operational capabilities. But the one thing that we've seen as a problem is, what was the problem we were trying to solve, at least me, provider perspective? Okay, we had paper charts that are physical, illegibility issues, discovery issues retrospectively, medical errors. All right, cool. So we digitize it so we can timestamps, easy to see everything. Okay, we can go back and say, well, you did this at 10:30 and got it. So solved the problem there. However, end user has no idea how to drive the car.
Yeah.
Right? It's like arriving at the airport and getting into a rental car, but it's not even like right now we can get into a rental car, and yes, it's not my car, and yet, no, I don't press the button and customize the seat and all this stuff. I can still drive the car. I can still get to where I'm going, right? Yeah. EMRs don't really feel that way for the majority of us that have to deal with them, especially if you're in different ones. And when I think about what you were saying, how we're not talking to our patients anymore, or we're not in that patient experience piece, which then leads to the improved staff experience. So both of those sides are affected. So in my mind, if I'm like, hey, wish list, I mean, we're spending all this time right now on Google Voice and Siri and Alexa and all these things. Okay, in my mind, is there a way we could develop voice technology? Because if we were able to do that, we can get back to talking to one another. And if there is an interface that can connect my conversation to an executable function, I don't need to memorize the maze.
Yeah.
That computer is going to help me to navigate the maze through talking.
Yeah.
And that's what I was thinking about, problem and solving the next problem.
Fantastic.
It'd be interesting.
That's awesome.
Voice technology.
So Jesse, I'm going to pick on you for just a minute, because you and I were doing some glances back and forth when Adil was talking about the adoption, and they wouldn't use this, and tasks always roll down. If you take it off the physician's task, it often rolls to the nurse or the MA, and then they're the support staff that are in, and then you've got them tied up. And when you see, how do you support your teams when there's an adoption you really want to go well? Kind of what's your approach to that, so it can be successful, to understand what the need is and support that adoption? Because just putting it out there and they will come, they're not going to use the app. And so how do you support that adoption when you look at your medical groups and bringing those solutions in?
Yeah, it's a great question. I think it goes back to what Daniel Burris was saying yesterday, and it's all about the connection and that trust, right? They have to trust that you're bringing something of value, and if you keep bringing something that isn't that valuable, or they question the value, or you've got data integrity issues, or whatever it might be, then you're not going to get there. So a couple things around building that trust is more frequent, lower duration, right? So just ensuring that they can see you. We were talking about it this morning. The further away you get from someone, the easier it is to forget about them or for that thing to become insignificant if it's a project or a program. So I can be really, really snarky on Twitter, but if I see you in person, then I'm going to be pretty nice, right? So the closer you get, whether or not you're out here from Twitter to Facebook to email, directly to a face-to-face conversation or a telephone conversation, the closer you can get to that, the more trust you can build in order to make that change. And the other thing is just to be inspiring, right? Is to tell them the why, connect them to the big picture. It's not ever because I told you so. And especially when we're talking about really obnoxious things like HEDIS measures or really in the weeds things, you have to bring that back to the patient. So it isn't that you have a 72% mammography rate. It's that in your practice, you have touched 8 women's lives and affected them that would potentially have had cancer. So that is a very different story when you're talking in healthcare than you've got a rate of 72%. And we've really got to be able to translate our scoreboards and dashboards and portals into humans and what we're doing for them and why we're doing it, even on the really obnoxious work, which some of it is, it feels like, how many times have you heard a provider say, I don't want to check any more boxes, or I don't care about insurance, right? So those are the things that you've got to be able to clean that, and just don't talk about checking boxes and what their insurance is. Let's talk about what we're doing to improve human life. Do it in a way that you trust me, that I'm really here for that. I'm not just here to make money, and with shorter, more frequent interfaces.
So we're back to people again.
We're back to people
and building
and connection.
trust
Yep.
and understanding what their needs are. Jesse, you said what makes you passionate. What makes me passionate is just I get inspired by the people that I've met here in the past 2 days and all of you, because I know that we're all out there trying to make a difference, and it's just really powerful when you meet people and you get inspired to continue to do the work you do, because we're all in it because we want to make a difference. And I still want to improve patient lives. I may not touch them the way I used to, but I still get to touch them in a very broad way and impact them. And so I want to thank you all for being here today. And I want to thank all of you for being here today, because we inspire each other to do what sometimes is really hard work and at times really fun work, and we have to be in it together. So thank you, and thank you.
Thank you very much.